First of all, thanks Salil for having invited me to participate in your IC. I've been told to talk about these three things, the problem faced between these three steps of vitreous surgery. So before I go to that, we should remember the basics of vitreous surgery to prevent complications in all these three steps. We know that the vitreous as a senile process separates from the retina. So we should remember there are certain number of list of conditions where this natural process does not occur and may pose a problem for us during surgery. Before going on to treating the eye, we should check our instrumentation outside the eye, which is very important. The cutter should be working, the suction should develop in an adequate manner. Starting with the surgery, port should be cleared first, then we go to a core vitrectomy, and then we go to in detail about discussing how a PVD is to be induced. We should know these conditions where PVD is less likely to be present naturally. I will emphasize in younger patients it's very important. The hyaloid is sticking onto the retina almost from the posterior pole to the anterior limit. In necrosed friable retinas also uveitic conditions, the retina is also inflamed, sometimes necrotic, and induction of PVD may not be advisable in such cases. So going on to PVD, we know that as a routine, we have to apply very high suction over the disc after we've done a core vitrectomy, catch hold of the vitreous as well as the posterior hyaloid and apply anterior traction. We pull up straight ahead from the disc. To catch the posterior hyaloid, we may have to do some tangential suction on the surface of the retina, but the pull should be posterior to anterior. If we pull tangentially, the opposite side of the retina is pulled in and we can see very commonly tears in the inferior retina. So as the PVD progresses, if we have not stained the vitreous, then we can very well see the progression of the separation of posterior hyaloid over the fovea, which becomes difficult in some cases when triamcinolone puts on a thick layer as we stain the hyaloid. Also watch for hemorrhages, especially in any particular quadrant, which may indicate sticking onto the hyaloid in that particular quadrant. And as I said, if we pull the posterior hyaloid superiorly while inducing the PVD, inferior quadrant breaks are very common. As the posterior hyaloid progresses from posterior to anterior direction, the various pathologies, this is a lattice degeneration, we can see how well the vitreous is attached to the retina. We should not be pulling over neovascular fronds, as Dr. Bhomaj has already pointed out. So these are the conditions where it is very unsafe to pull through these areas because they have a very strong vitreoretinal adhesion. We progress with the PVD till this area is left and we trim it over this area if we are not able to gently separate it from the retinal pathology. When we induce a PVD in the case of detached retina, if there is a partial detachment, we start with inducing the PVD over the attached retina first and then go on to the detached retina where we have to pull the PVD tangential to the retina. Sometimes pull on the detached retina increases the amount of bullous nature of the retinal detachment, and if the vitreous is not cleared, the vitreous may in fact pull the vitreous into the port as you remove this instrument. We can avoid this by putting a bubble of PFCl to apply counter traction onto the retina, as well as sometimes we can endodrain part of the fluid to reduce the bullous nature of such a bullous retina. Going on to inducing PVDs in cases of neovascularization, as Dr. Bhomaj has pointed out, we should never do this because it will pull out the vascular plugs and lead to severe bleeding. So we use different technologies or different techniques when we address such an issue. We should remember that in addition to other neovascular pathologies, diabetes has a ischemic retina and which is very thin in long-standing TRDs in some cases. Technological advances, the cutter works like a multifunctional instrument now and we can do a combination of segmentation, delamination or dissection with a single instrument rather than doing multiple exchange of instruments. We can use sometimes stains of triamcinolone to stain the posterior hyaloid because these pathologies are very commonly associated with vitreoskisis, and staining the vitreous helps us get better visualization and see the separation of the hyaloid at different points on the retina. Going on to the second topic of iatrogenic retinal breaks, we should see that we can induce these breaks by indirect trauma by pull on the vitreous. Here I would like to emphasize we should do minimum number of instrument changes, minimize aspiration during removal of instruments, avoid a high intravitreal pressure when the instrument is removed, and endotrain bullous RDs to make it shallower or use PFCLs to avoid pulling the retina into the port. Other indirect ways in which we can induce a retinal break is that during induction of PVD, as I have mentioned, If cutters are not working properly, the vitreous can get caught up and get pulled up. Direct retinal breaks may be induced in a new vitreoretinal surgeon or a young surgeon when he is not used to different visualization systems. We have to use a high magnifying lens when we deal with the macula, and limited stereo acuity and monocular clues have to be used in some cases when the pupil is not dilating. Patient movement also has to be looked into, and we have to do good teamwork so that nobody pushes on the operation table or your chair during fine movements over the macula. During epiretinal membrane removal, narrower fold of the high magnification lens has to be looked into, and we should remember that the retina is a concave surface rather than like a convex in the case of a capsular axis. We have to keep the forceps away from the retina and apply the pressure pull on the forceps in a tangential manner. During diabetic vitrectomy, we may induce retinal breaks during dissection, so we have to be well wary of what type of pathology we have, whether there is a focal point of anchorage or there is a broad attachment. Bleeding also may interfere and affect our surgical. During PVR, we should remember the posterior retina is thicker than the anterior retina, and peeling has to be proceed from a posterior to anterior direction to prevent retinal breaks. It also can be related to retinopexy. I think Dr. Parag is going to deal with this. And coming to residual traction, which remains at the end of surgery, we should first, depending on the different pathologies, the traction may be pre-retinal, it may be intraretinal, or it may be subretinal. Pre-retinal pathology may be identified with the help of stains. We can use triamcinolone or trypan to identify residual membranes. We can mechanically with a retinal massager assess the retinal laxity in case of retinal detachments, and also use PF cells or fluid air exchange to detect the residual traction on the retina. We should remember that air can pass subretinally if we do a fluid air exchange with high amount of traction around the break. Retinal sheen, pigment entrapped in membranes may also give a clue of residual membranes remaining on the surface of the retina. We can use these instruments to dissect these membranes. However, if there is an intraretinal shortening, it's very difficult to relieve this traction completely. In younger patients with inferior pathology, if breaks are not there inferiorly, we may combine a scleral buccal along with a vitrectomy to help tackle part of the shortening. But if not, then we have to do a retinotomy. And we should remember that it should be generous. Good hemostasis should be achieved before we do this, and there should be no traction left or vitreous left onto the posterior edge of the retinotomy. We go with these steps of retinotomy. I can't discuss these in detail today. If there is subretinal traction, we should remember that not all subretinal bands need to be removed. If it's influencing macular apposition or if the break reapposition is being affected, then surely we should deal with these bands. Sometimes the bands need not be removed in toto, they can be just segmented under the retina and left behind. And small retinotomies can be used under wide angle systems. Either you can pull the bands or bimanual dissection under a chandelier system is very useful. We also should remember to tackle this traction, we should also remember the help of a supplemental encerclage if needed, especially in cases of inferior pathologies and also in phakic patients where access to the vitreous base may be difficult. So we then proceed to the next steps of vitreous surgery. Thank you.